He said the same thing what you said. That the podium speaker.
I mean, we have repeated.
Can we split it?
Good morning, Professor.
Sometimes, once the problem.
Hello, students on the Zoom. Can you hear me, guys? Can you folks hear me on the Zoom?
Yes, Professor.
Okay. I'm just checking whether the sound is okay or not from your end. It's good?
It's good, Professor.
Oh, yeah. Muted. Good morning, everybody.
Morning.
How's everybody? Good. No pathology? No disease condition? No. Nobody? It has got to be a good condition. And so let me take care of the attendance first. Those just here right now, let me take them first, and I know how many are in the Zoom. Marianne, Guba, not here. Victoria Guba, not here. Cody,
Here.
thank you. Maria Alamo,
Here.
thank you. Angie Iris, I think she swift with whom? Sandra. Yes?
Yes.
Janet Fernandez, thank you. Bradley Leonov, thank you. Nicole Castro.
Here.
Nicole emailed me. I didn't respond to your email. Did I respond to your email? No. But I know you emailed me.
Yeah, for the syllabus?
I will talk later on.
Okay.
Liberson. Katamichan Liberson, she's not here. Jen Chen.
Here.
Corey name. Ivy.
Here.
Nicole Davis. Okay. Desiree. Robledo Desiree.
Professor Emma?
Yes. Are you Zoom?
Yeah, because of my COVID test, I needed one in order to go to campus.
Okay. Yang Wang. Thank you.
I thought it was for
Erika Bornakis.
Here.
Gabriela Candelo. Andrea Hernandez. Okay. Beatriz Hernandez. Thomas Hong. Okay. Today. Okay. Stephen. Yeah. Ivan Jimenez. Here. Benjamin Geronila. Here. Jasmine Gill.
Here. Kayla
Faustino. Andrea Livadio.
I'm here.
on Zoom.
Yes.
You folks are at Vancouver, Marianne. You are Marianne.
No, I'm in Florida. Marion.
Did I miss anybody?
Yeah.
You are
Rosie
on the
Kasuga.
class 30.
I'm Kasuga, class C.
Which one?
Rosie Kasuga with a C.
Cedar.
Kasuga with a C. Right there.
So. And you are
Susan Barrientos. Barrientos.
Kalyan,
Barrientos.
CA.
B. Yes.
Sorry about Did I call Susan, right? Okay. Anybody else? You are first story. That's cool. Okay, I'll email you. And I didn't got your response. Thank you.
Okay, I'll
So I need your response from that email.
Okay.
Thank you. Okay, folks. Yes.
I didn't hear my name. My name is Andrea.
Yeah.
I didn't hear my name.
Andrea Lopez, you changed with whom? Did you change?
Yes, I'm out.
Okay. Lopez, can you email me later on, please? Thank you. And I'm not, the students on Zoom right now, I already have 30 students over there. That means you guys are okay on that other end. I'm not going to call your name. You already joined. I have 30 on your, at the Zoom end. Okay?
Thank you.
So you guys are present. Okay, so folks, please, you are what?
Julia
Mendoza. Legal? Did you change with somebody? Okay, and there is there, just said, and you will come for two.
That's a salty one.
Have a seat. Okay. You folks can hear me clearly at the back? Yes? Okay. If not, I have this option. Can you hear me now?
Yeah.
I'm not selling any Verizon. I'm not selling any Verizon product. So, okay.
Verizon.
So that is, can you hear me now? Okay. I upload also PowerPoint regarding cardiovascular system. Cardiovascular with the respiratory section. Is that correct? Recent upload. Is that correct? Somebody emailed me also. I upload only on the already on the canvas. with a study guide for the respiratory section. And also I am planning to have some form of extra credit. Is that okay? Yeah. So some form of extra credit, whatever the PowerPoint I am uploading, you need to read, digest, and retain. So if you retain all those PowerPoints, information, that might help for the extra credit. Extra credit means extra lifeline. So some of the students, they do need lifeline. Is it clear? Yes or no? Okay, so today I'm going to discuss chapter 30 and 31. 30 and 31. I'll talk to you later on. Your full day, I believe. Yes? Okay, so let's start our discussion. 30 first and then 31. Time to time during discussion, I will go sidetrack. That sidetrack is important. So please pay attention doing that also. That something might pop up for the exam. Okay, so everybody ready? Okay. So chapter 30 is about the respiratory tract infections, neoplasms, and childhood disorders. Now also, when you go forth with the chapter 30 and 31, make sure, I repeat, make sure know the normal anatomy of the respiratory system. That is the important. No excuse. Not only normal anatomy, with the function. I know alveolus. Alveolus is the terminal part of the respiratory tract. Is that correct?
Yes.
What it does? What is the role of alveolus?
Gas exchange.
Yes.
Gas exchange. Between what and what? Between the blood in the pulmonary capillaries and the alveolus. Alveolus has the air and my pulmonary capillaries has the blood. Gas exchange. Alveolus is the terminal part of the respiratory tract. Now we do have, look at the lung. Lung is covered by a membrane we call what? What is it covering over the lung called? Covering or membrane over the lung.
Pleura?
What? What you said?
Pleura?
Pleura.
Flora.
Yes, very good. Pleura. And that pleura has two layers, visceral layer and the parietal layer. And then in between those two layers of the pleura, we have serous fluid. And the purpose of serous fluid is to prevent friction between the visceral layer and the parietal layer. That is the purpose of the pleural fluid. Is there any pressure within the pleural cavity?
Negative pressure.
Negative pressure. Why we have negative pressure?
It won't collapse.
We prevent the collapse. To prevent the collapse of the lung, we do have to have negative intrapleural pressure. Is it clear, folks? So that is intrapleural pressure has to be negative to prevent the collapse of the lung. Now look at within the alveolus, we have different types of cells also. Type 1 alveolar cells, which participate in gas exchange. Type 2 alveolar cell does what? What is the role of type 2 alveolar cells?
Is it to control mucus secretion?
Pardon?
Control mucus secretion and
Can you clear? Can you say loudly?
is it to prevent secretion or?
Type 2 alveolar cells.
Right.
You said surfactant?
Yeah.
Oh, yes. Surfactant. Surfactant. What is the role of surfactant? Prevent,
Friction.
reduce the surface tension. Is that correct? Reduce the surface tension. And also to prevent the collapse of the lung. Intrapleural pressure, I said negative, to prevent the collapse of the lung. Surfactant does the same thing to prevent the collapse of the lung. Okay. We divide the respiratory tract into the upper and the lower. Upper respiratory tract has the nose, the nasopharynx. Nasopharynx is the part of the pharynx. Is that correct? Nasopharynx is the part of the pharynx. Pharynx has how many parts? Three. Nasopharynx, oropharynx, and laryngopharynx. Those are three parts of the pharynx. So my respiratory tract, nose, oropharynx, and the larynx. Lower respiratory tract, below the larynx, the part of the lower respiratory tract. What is the structure just below or distal to the larynx? What is the tube called? Trachea. Trachea. So that's what they're talking about right now. Lower respiratory tract has the lower airways up to the lung. And the distal most part, we just said, what? Distal most part of the respiratory tract? Alveolus. Alveolus. Distal most part or the terminal part. And my respiratory infection can involve both. Maybe the upper, maybe the lower, maybe the both. I went to the doctor, that said you have upper respiratory tract infection. I went to the doctor, he did perform my X-ray of the chest, and he said you have lower respiratory tract infection. Maybe I'm suffering from pneumonia. Is it clear? So that's how they write down upper respiratory tract infection or lower respiratory tract. Okay. These are the common infections, like common cold, influenza, pneumonia, tuberculosis, fungal infections. These are all important. Now, if you look at the factors affecting the signs and symptoms of the respiratory tract infection. Number one, the first factor is number one is the functions of the structures involved. The function of the structures involved. Number two is the severity of the infectious process, and of course, the person's age and general health. If I'm suffering from chronic disease, already suffering from cancer, now I have respiratory tract infection. That respiratory tract infection in my body is going to be severe because my body is immunocompromised. I'm suffering from cancer right now, or other organ cancer. Is it clear? So that is the person's age and general health status. Now, please remember and highlight common cold transmission. It is a viral infection of what? Of the upper respiratory tract. Is it clear? Common cold. Before you used to think that this common cold is caused by a single virus, but now say no, it's a combination of virus. Combination of virus causes common cold. Like what? Rhinovirus, parainfluenza virus, respiratory syncytial virus, coronavirus. Right now, coronavirus is going on, and adenovirus. Coronavirus is not a new virus. It was there before, but it was not causing that problem. Now highlight the greatest source of spread is my finger. I am touching various places and touching my eye or my nose. That's the route, port of entry. Is it clear? So the fingertips. Fingers are the greatest source of spread of infections. Highlight. And then this common cold usually present with cough and sneeze. Might be a little fever, low-grade fever. What's going on? during common cold, the nasal mucosa and the conjunctival surface of the eyes are the most common portal of entry. There are two things over here. Conjunctival surface, which is my eye, and my nose, nasal mucosa. My infected fingers are touching those areas, causing portal of entry. Please highlight and remember. So common cold is bacterial or viral? Common cold infection? Viral. And also please remember, for any viral infection, if it is viral, diagnosed viral, we cannot prescribe antibiotic. We have to have antiviral drug specifically. If I prescribe, doctor said you have common cold and you have viral, and he prescribed antibiotic. No. Antibiotic is not going to work because it is viral. He has to prescribe antiviral drug. Please remember. They are in the textbook. There are a bunch of antiviral drugs like hematidine and others. There are 4 of them in the textbook. First generation, second generation. Please remember those antiviral drugs. Okay. We already said that one. The most common port of entry for cold virus is my conjunctival surfaces. Is that correct? So please remember, I said already, fingertip spread, port of entry, my nose and my eye, conjunctival surface of the eye. Now, rhinitis and sinusitis. Rhinitis, it is the inflammation, please highlight and remember, it is the inflammation of the nasal mucosa. Rhinitis. Sinusitis, it is the inflammation of the paranasal sinus. Please remember the anatomy of the paranasal sinuses. There are different paranasal sinuses. I think the PowerPoint is there. So where they are located? And these paranasal sinuses are lined by ciliated columnar epithelium. What they do? What they're doing in the paranasal sinuses, those epithelium? What is the purpose of ciliated columnar epithelium with goblet cells? We have maxillary sinus, we have frontal sinus, sphenoidal sinus, sphenoidal sinus, and ethmoidal sinus. All those sinuses are lined by mucous membrane. And those mucous membrane produce or secrete mucus. That mucus needs to be drained into my nasal cavity. And with the help of their passage, they have opening from the paranasal sinus into the nasal cavity. If that opening is blocked because of inflammation, buildup of mucus, bacteria growth, inflammation starts. Is it clear? That's how it's taking place. So please remember, these are paranasal sinuses. These are air cells connected by narrow opening, also we call ostia. There's an opening called ostia with the superior, middle, inferior nasal turbinates of the nasal cavity. Those are the passages from the sinus towards the nasal cavity. We have maxillary sinus, frontal sinus, sphenoid sinus, and ethmoid sinus. Okay. Now, rhinos is a combination of rhinitis and sinusitis. Acute rhinosinusitis. It may be viral, it may be bacterial, or it is a combination. And we divide this rhinosinusitis into acute, subacute, and chronic form. Is it clear? Classified in a 3 group. Maybe acute, subacute, chronic. Based on the duration of infection. So please remember the duration. For acute, lasts up to 4 weeks, or almost about a month. And subacute lasts from 4 weeks up to 12 weeks, up to 1 to 3 months. If it lasts for more than 3 months, then turn into chronic. Is it clear? Remember, chronic are when the infection lasts, extend, or persisting for months, more than 3 months, it got to be chronic. Infection may be viral, may be bacterial, or may be combination. This is allergic rhinosinusitis. Occurs in conjunction with allergic rhinitis. Pollen going through my nose, and that causes allergy. Mucosal changes are the same as allergic rhinitis. Inflammation will occur, secretion will occur, and sometimes they become infected. So how they present? We feel a nasal stuffiness. Nasal stuffiness. Sometimes it's itch inside. And burning of the nose. Frequent bouts of sneezing. Recurrent frontal headache or watery nasal discharge. So what we're going to prescribe? Treatment is oral antihistamine, nasal decongestant, and a newer form is intranasal Comonil. And this, if I have a history of hypertension, I'm having high blood pressure, I'm diagnosed, I'm having medication, hyperthyroidism, or having heart disease, having medication. The medication is 100% no, is oral decongestant. Please turn off. So nasal, oral decongestant are no if I'm already having hypertension, hyperthyroidism, or heart disease, or diabetes. Sometimes if you go over the counter, it says the oral decongestant cause hypertension. This is already written over there. So please remember, I said there are conditions, those conditions in which oral decongestants are contraindicated. Okay. Anybody any question? No, yes? Okay. Is everything going in? Okay. Influenza, very important. Influenza, we have different types. Type A is the most common. Can infect multiple species. Causes the most severe disease. We divide, this A is further divided into hemagglutinin type A, neuraminidase type A. One is help in binding, the other one help in viral replication. So please go over with the influenza infection. We do have vaccination for influenza, is that correct? Influenza, pneumonia, those are the vaccinations given every single year. Oh, these are the drugs I was talking about. These are all antiviral drugs for viral infection. Matadine, Dimetadine, Zanamir, Oseltavir. These are the drugs which are used for viral infection. If I have bacterial infection, these drugs are trash. It's not going to work because these are antiviral. For viral infection, I have to have antiviral drug. Okay. Please put a star and remember. We do have vaccines for influenza vaccine.
Professor, can you go back to the last page? You're going really fast.
Pardon?
Can you go back to the previous page?
Oh, okay. This is the antiviral. Tanya, are you looking for this one?
Yes.
Okay.
Done.
Okay, let's move on. I said about the vaccines, so please remember the vaccines for influenza. Most commonly, influenza vaccines are given IM, intramuscular. They start this one intranasally, and still there is a controversy about the live attenuated vaccine, which is given intranasal spray. Efficacy of this one is still in doubt, the second one, but the one in IM is recommended. Okay, pneumonia, the important. Okay, before I go into pneumonia, we said, if you remember, my respiratory tract, they line with ciliated columnar epithelium with goblet cells. That's what we said earlier. Is that correct? And these cell epithelial lining, they do secrete mucus. And with the help of mucus plus cilia of the cell, we call mucociliary blanket. What? Mucociliary blanket, right on the surface of my respiratory tract. What they're doing, they're protecting the respiratory tract against dust, microorganism, any foreign material. They prevent this mucociliary blanket capturing those dust, foreign body, so that they can reach to the alveolus. And I've been smoking for 15 years. My mucociliary blanket is gone because of my smoke. And that, as I don't have that mucociliary blanket protection, I'm susceptible to infection. That's why there's smokers, they do suffer from respiratory condition. They do suffer from respiratory because the mucociliary blanket is gone. Is it clear? No, yes? Okay. Okay. What is the normal pH of the body?
7.4.
Straight?
7.5 to 7.45.
7.45.
7.35 to 7.45.
Please remember, can you speak loudly, please?
7.35 to 7.45.
That's the key. That's what we need. Now, this pneumonia, which is, if you look at that one, it says, is a respiratory disorders involving inflammation of the lung structures, which includes my tube, which you call bronchioles, and the air sac is my alveoli. That is my pneumonia. Inflammation in that part causes pneumonia. Please remember the causes may be infectious or non-infectious. Non-infectious agents are, please highlight, these are by mistake food or fluid goes into my lung, or from the stomach goes into my lung. That causes a pneumonia we call, what pneumonia, anybody?
Aspiration.
Aspiration pneumonia. Aspiration pneumonia. The pneumonia is due to the aspiration of the fluid, or I'm in the hospital, I'm bedridden, somehow my stomach secretion goes into my lung. It's called aspiration pneumonia. I went to the hospital with UTI, urinary infection, but end up with pneumonia. I'm gone. Pneumonia killed me, not the UTI. Okay, so please remember, we do have infectious agent, and also please remember, most common pneumonia is caused mostly bacterial origin. They are bacterial origin pneumonias. No matter what, community acquired or hospital acquired, mostly bacterial origin. Is it clear? Now, if you look at, we call hospital acquired, the other term in the textbook they use also call, anybody? Nosocomial. Nosocomial. Please write it down and remember someday. Nosocomial or hospital acquired pneumonia. After admission to the hospital within 48 hours, I'm having symptoms, fever, and all those. They did X-ray, they said you start pneumonia within 48 hours. Before was not there. So hospital acquired also we call nosocomial pneumonia. Okay. Now, if you look at that, there are some factors like an exceedingly virulent organism or bacteria. If they are highly aggressive, a small amount is enough to cause inflammation. And depends on the large inoculum. Larger the bacteria, number of bacteria, count of bacteria enters or virus enters, severe the infection. Duration of incubation will be shorter. And also depends on my immune status. Immune status. So impaired host defenses will aggravate the condition. Please remember now the pneumonias. I think we already said that one. So according to the source of infection, maybe a community acquired. I call CAP, community acquired pneumonia, CAP, HAP, HAP, CAP, and HAP. HAP is my nosocomial. Okay. And most common cause is what? Most common cause of microorganism is bacterial. Now the pneumonia, according to immune status of the host, pneumonia in the immunocompromised person can happen also. With the pneumonia, go with lobar pneumonia in the textbook. It is not in the PowerPoint right now. And in 1976, in Philadelphia, they first find that that microorganism in the cooling system of the air conditioner. air-conditioned water was infected, and that causes pneumonia. We call what pneumonia? Legionella pneumonia. Please write it down and remember. Legionella pneumonia. Start with L. They first found in Philadelphia in 1976. And person who is smoking, who has chronic disease, they are more susceptible to that bacteria, Legionella pneumonia. We call Legionnaires' disease or Legionella pneumonia. What else were there? So I'm not still in the tuberculosis, I'm still in the pneumonia. So in order to protect us, we do have vaccine. Is that correct? To protect against pneumonia. We get vaccines. So please remember vaccine for pneumonia. Please go vaccine for pneumonia. If I'm allergic to egg white, you need to mention that are you allergic to anything? If I'm allergic to egg, I cannot have that vaccine. And now, I was unconscious in the hospital. Somehow my gastric juice, the gastric content aspirated into my lung. Look at my condition. And that aspirated content of the stomach causes a pneumonia. And that pneumonia we said what? Aspiration pneumonia. For that, no vaccine. Doctor can have vaccine for aspiration pneumonia? No, there is no vaccine. Is it clear? So please remember. Do we have, in a normal healthy lung, do we have a dead space? Dead space in the lung?
Yes.
Yes. What do you mean by dead space?
The place where no gas exchange occurs.
Yes. The part of the lung or airway tube not participating in gas exchange. That is my dead space. If that is in some part of the lung, there is no gas exchange. Like if you look at those alveoli, terminal bronchiole, there is no gas exchange. Gas exchange only takes place within the alveolus. When the air is within the alveolus, gas exchange starts. So we do, normal healthy lung do have that space. Now, if I'm suffering from pneumonia right now, what's going to happen to my dead space? Is it going to increase or decrease? I'm suffering from pneumonia right now.
Increase.
Increase. Dead space increase. The lung tissue becomes inflamed. They are not participating in gas exchange. Dead space increase. Please remember under dead space. Okay. We do perform various types of measurement to assess the lung condition. Is that correct? Where is the test we perform? We call force, force expiratory volume. Please write it down. Force, F-E-V, force expiratory volume. In 1 second, we do perform tidal volume test. What is tidal volume? What is tidal volume? What is tidal volume? System anatomy, folks. We are pulling again over here. What is tidal volume?
That's the total amount of air that goes into your lungs. Or
Can you
It's the volume,
fine tune up anything?
the volume of air you breathe in at a relaxed state.
Breathe in,
Yeah,
not out.
breathe in,
In and out.
out. Yeah.
Now, please. So in and out. Volume of air going in and out for breath, each breath. That is my tidal volume. Okay, so look at those, so many things like this. I'm discussing, pulling in this part with anatomy, and this is needed. If I don't have that thing in the background, I'm lost. So the reason is, if you look at that one, force expiratory volume. Force expiratory volume, I said earlier, if I have that volume is deficient, they said you are suffering from asthma. Asthma. So in order to diagnose or confirm your asthma, I need to assess your FEV, force expiratory volume. How much air you can breathe out. Because in asthma, the tube becomes inflamed and becomes narrow. Anybody have asthma? It's very severe. Very severe sometimes. You don't smoke, right? Okay, so it's good. Okay, so FEV1, and I said tidal volume. And the thing is, what is partial pressure? It's everything kick in my head over here. Right? What is partial pressure? Yes. Anybody? Open for the floor. Question. What is partial pressure? Is it rest and digested? Everything is gone. So partial pressure is the pressure of a gas in a mixture of gas. Please remember, it is the pressure of a gas in a mixture of gases that is called partial pressure. I'm inhaling atmospheric air. That atmospheric air is not that have only oxygen. They have nitrogen, they have oxygen, they have carbon dioxide. Is it clear? So that is the partial pressure. Okay. Now let's start this topic. This is tuberculosis. Now this disease was well controlled, especially in the United States. But since 1980s, with the eruption of AIDS for people suffering from AIDS, the incidence of tuberculosis is going up. That means people who are suffering from AIDS, they are now suffering from the tuberculosis. Please remember. So incidence of AIDS, HIV or AIDS, make the incidence of tuberculosis go parallel. But this tuberculosis is common throughout the world because of the crowded living nature. People are crowded together. In United States, like correction facilities, people living in crowd. In jail, correction facilities. Over there also, please remember the cases of tuberculosis is higher. Incidence of tuberculosis is higher where in United States where the people are living in crowded condition, like correction facilities, like shelter home, homeless shelters. Very clear? Now, it's caused by, this tuberculosis is caused by the name of the bacteria is called Mycobacterium tuberculosis. It is a bacterial infection, not viral, not parasitic. It is a bacterial infection. Single bacteria, no other bacteria, other help needed. This is only one bacteria causes tuberculosis. Okay? Now, please remember the second line in the PowerPoint. And this happened, the second thing is happened because my macrophage is a body protective cells, macrophages, which do phagocytosis. So when macrophage is coming across with the tuberculosis microorganism, they go and surround it. These macrophages go and surround the tubercle bacillus. As a result of this macrophages with tubercle bacillus, they form a structure we call tubercle. What is called tubercle? Within the tubercle, within this tubercle, we have this microorganism. But this microorganism, as it's surrounded by macrophages, this is dormant. Is it clear? Now, I start suffering from some chronic disease, immunocompromised. This tubercle with bacteria gets upper hand, reactivate. Within this tubercle, microorganisms get upper hand, they start multiplying and spread the infection, tuberculosis. Initially, I was protected by macrophages. Is it clear? No, yes. And tubercle with the microorganism, they form what structure? What is that called? Mycobacterium surrounded by microorganism surrounded by macrophages. What is that structure called? Tubercle. Tubercle. And this microorganism also has a protective layer around. Tubercle bacillus, they have a protective surrounding of waxy material. Okay. So please highlight the outer waxy capsule of this microorganism makes them more resistant to destruction. Even though the macrophages want to go and eat, they can't eat because of this protective covering. Is it clear? In fact, this tuberculosis infects practically any organ of the body. The lungs are the most frequent site. Tuberculosis of the lung. Lung tuberculosis, most common site of tuberculosis. Now, this tuberculosis can also spread to other organs also, other structures also. May involve the kidney, may involve the bone tuberculosis. Is it clear? Start in the lung. With the help of bloodstream, they spread to my various bones. And that tuberculosis in my bone, that is called miliary tuberculosis. What tuberculosis? Miliary tuberculosis. M-I-L-I-A-R-Y. Miliary tuberculosis. Miliary tuberculosis is the spread of tubercle bacillus where?
In the bone.
In the bone. That's it. Okay. And this macrophage with the tubercle bacilli, they are causing cell-mediated immunity, cell-mediated response. And I said even for the time being, we are protected with the help of macrophage because macrophage forms the tubercle. And within the tubercle, we do have microorganisms, that is microtuberculosis. They are dormant, not doing anything. They're dormant means right now they're resting because they are surrounded by police officers. Those police officers are my macrophages. Is it clear? Okay. We do have microtuberculosis. One is called hominis type, and the other one called bovine type. Hominis, which we affect in the human, this tuberculosis Mycobacter hominis affect my lung, in the lung disease or human disease. Look at this one. This infection is the airborne infection, spread by minute droplets, nuclei harbored in the respiratory secretions of a person with active tuberculosis. I'm living in a correction facility. I'm living in homeless shelter. As I says, living under crowded and confined conditions increases the risk of spread of the disease. Not only does crowded condition, people with AIDS, they do suffer from tuberculosis. The incidence of tuberculosis in AIDS patients is higher than normal population. Now the bovine tuberculosis, which occurs, tuberculosis which is in the cows, and that's what they call bovine tuberculosis, acquired by drinking infected milk from cows. Now it is eradicated. How? What makes this cows of bovine tuberculosis eradicated? Anybody? Bovine tuberculosis, we don't suffer from bovine tuberculosis. We do suffer from hominis type. Why bovine is not causing any harm?
Pasteurization.
Pardon?
Pasteurizing milk.
Can you say again, please?
Pasteurization.
Milk is pasteurized to kill those microorganisms. Pasteurization milk has taken care of my bovine tuberculosis. Now, we do protect against tuberculosis throughout the world. We do protect against tuberculosis by means of vaccination. Please remember, I believe they have over here. Okay, so please remember about the vaccine which protect against tuberculosis. We call BCG. BCG. It is in the textbook. One shot. Protect for the rest of their life. Now, if somebody throughout the world, this is recommended, except in the United States. United States doesn't follow this protocol. Is it clear? Now, if somebody is coming from abroad and they said, we did your tuberculosis skin test, it came positive. Yes, it's going to be positive because I had BCG back home. They're going to make positive. In order to confirm, please listen carefully, in order to confirm tuberculosis in my body, they need to do X-ray chest. confirm with not with tuberculin test, with X-ray test. Is it clear? To confirm that I am suffering from tuberculosis. I'm going to have tuberculin test positive because back home they gave me BCG. What was mandatory. So in order to confirm it, we have to do what?
Chest X-ray.
Chest X-ray.
Chest X-ray. Okay. Okay, let's see what we have. Tuberculin test. Do you guys know what is the measurement for tuberculin test? When they put intradermal tuberculin test injection, it is almost 10 within 72 hours. We go for reading. 72 hours, we go for reading 10 millimeter. If it's more than 10 millimeter, tuberculin test is positive. If there is no inflammation, there is no redness, negative. Or if it's smaller than 10 millimeter, negative. Tuberculin test. Okay. Yeah, that's what it says. If you look at this one, result from the cell-mediated immune response implies that a person has been infected with mycobacterial tuberculosis and has mounted a cell-mediated immune response. Does not mean that the person is active tuberculosis. Because my tuberculin skin test came positive doesn't mean I have tuberculosis. In order to confirm it, they need to perform the X-ray. Please remember, it is not in the PowerPoint, but it's in the textbook. Folks, let's have some break. Is that correct? Is it, you guys want some break? Have a 10 break. 10:20. 10:20 returning time. Right now, 10.
Thank you, Professor.
You're welcome. Zoom also, 10 minutes break. Go and stretch out, have some fresh air. Cody, right?
Yeah.
You emailed me a couple of weeks ago,
Yeah.
so I didn't respond to you.
For the test or?
For test, for test.
Yeah.
You're okay now?
Yeah.
Good.
Thank you.
And Jasmine.
For the IPE. For the IPE.
Yes.
Do you get extra? Yeah.
Everybody? Oh, I forgot to ask. Let me ask. So, and you have the recording
Well, they took attendance, the TA.
attendance sheet?
Yeah.
Only mentioned.
I don't know.
Okay, yeah, then I need the attendance sheet.
Okay.
Okay, so I will ask everybody. I forgot. Yeah, you-
No, but just the finals community.
I know. You don't have a choice. But you're really. You're just one like it. And then she always runs this class over university, but she's gonna get through. I'm like, no, nobody go there. The whole time.
Surprising.
What I can do for me.
Yeah.
Good.
Yeah, it's,
Other than saying, huh? To go? Oh, like they're. Sometimes, yeah, I'm not I don't want to rush. This is not like, what if there's an accident? What if it's traffic? And then I'm going to be anxious and then I'm going to be, it's just going to be bothering myself. You know what I mean? Because I'm making sure that everything's closed, like, you know, there's no noise. Like, very fun. But yeah, and I was just like, oh my God. Like, he was making sense. Even that. Because couldn't even concentrate. I was so scared. Because noise is terrible. But I was really low.
I feel bad.
How did it go?
I would say that that's a question.
You don't want to know how it is.
Last test? Like blood type.
What did you get?
Patient.
No, but what did you get on the ears?
So
Okay, that could be done.
A, B, and
There was no negative
There was no
I
negative
got
positive.
twos.
So I select all that apply on that one, so I don't know if it was, I got.
Okay, I'll check that because
So I got mixed up.
I remember I put
I
negative positive.
Yeah, that one didn't have negative.
Then I will check that. Because
And then she.
In the, on the canvas, right now, we're saying question number 31, always change. But I will check with the blood groupings.
Yeah.
Anything else?
There was one, there was another
I'm
one.
not going to change anything.
Okay, there was one with the values. One had like something.
I was like, I had my chin right here. And then I
One talking about like abnormal ranges, I marked some, but
Sorry, it's not.
I know, I okay.
And
Just making sure, because I
I,
know like they were close, and then sometimes, you know, people will say, oh, that's not, it's not that close. So then, yeah, and then one was 5.8, so then I marked the others. Have
I was
no.
like,
all those PowerPoints and uploading has some ways.
Yes.
I feel like
Okay, thank you.
Okay?
I was being an human, and I was like, yeah, literally forgot everything. Did you guys get to me like on time? Because I felt like by the time we left, it was already 10:30. Yeah.
I think we left them. Yeah.
Yeah. And then she gave us those sheets again. I was like, oh my god. Two of them. Yeah. I think
And they're all
Thomas.
She said?
Yeah.
And yet she didn't say, she just said that we have to, that we have to be having a return. Make sure you have a non-ship because you will have the tournament.
Who's the next one?
Really?
I'm not sure. Like, Patho Ch.
I know, that's what I know, there's always so much miscommunication. Huh? Yeah, I submitted it. I started typing it like I had told Gabby, but I was like, oh no, I'm not gonna type all this too much. I'm like, you know what she said, we can just, use the thing, so I was like, okay. I have already finished it, I just need to do the cover page and the back page, so I just submitted it. I've been trying to do that, because it's 8 hours too, and I only want the time. So I've been, when I'm at work, I just have it up, and then I'm like, nah.
Really? Oh, no. Yes. I'm running this. You don't know. When food nutrition. My number.
Oh, anyone, any of them, yeah. I remember I asked him about that. I was like, is there a specific one? And he's like, just beginning, and just submit it. Mm-hmm. Yeah, he said just do it. There's another one, I think, where it's gonna be on Wednesday, and then I asked him to, and he said just.
I did a lot of administrative work.
Not the medication.
Where did we submit that one?
Because I was tossing up between
In the same campus, no?
like health administration, like clinical. So you get
Because I'm not in the class, but when I did it, I remember. Yeah.
genetics.
I remember I was asking. Yeah.
I was like, this
I
is.
can't believe it's so stressful.
I was like, I'm like, sorry.
So my coworkers say it too.
So then I he does nursing. I started through this. I was trying to get.
I don't know. Yeah, and then I all know they're all close.
Yeah, then COVID hit, and I was like,
Because I don't know.
yeah.
Like even that last semester. Okay, it's like over here.
It's hard.
Yeah, but those people there, that was already the second.
Should have just been in.
Yeah, the people who were in the last class, you know. Because I think they were from the floor before. So they said that they had really good teeth. So they're like, we don't have choice. They're having a long, basically.
It's so easy. That's all. It's all. And he's never discovered.
Angel, I'm sorry. Oh, I'm sorry. Oh my God, I'm sorry. Okay. Okay, thank you.
Like a course.
Yeah.
It's like a semester. Six months.
You can mute when we're on break. Is there a way you can mute it when we're on break? Mute the,
Yeah.
okay, because I know I got a message saying that they can hear our conversations at home.
You have this. You have watched
I
this.
was, I remember I was like,
I saw it, but I didn't watch it.
I think you did this one probably because I didn't want him either.
I got it from a, you know, have you ever been to Thursday show?
Oh, no,
One Punch.
He was
I think it's hilarious.
I had him for.
Yeah, I don't know his name.
We've had him for.
I should know it.
Oh, the main character.
Yeah, see that?
That was it. Broke the second one.
It's
I don't know.
from that whole part.
Yeah, but yeah,
Okay, folks,
that's not
let's get back.
you get like.
They had him in it.
Oh, no, that's fine.
Yeah.
Student on the Zoom, you folks can hear me?
Yes, Professor.
Yes. Yes.
One more.
So folks, let's roll. The slide is laboratory test to diagnose histoplasmosis. In the textbook, we do have various types of fungal infections. Make a note, fungal infections. One of the fungal infections right now is, on this slide, it says histoplasmosis. Histoplasmosis is one of the type of fungal infection. We have other types of fungal infection. There are 3 different types over here in the textbook they discuss: histoplasmosis, coccidioidomycosis, blastomycosis. Blastomycosis, coccidioidomycosis, and histoplasmosis. Those are the 3 different types of fungal infection. Fungal we do see in the form of yeast, in the form of mold. Most of the fungal infections, they occur in dimorphic form. That means they vary with the temperature. Dimorphic means some are okay with body temperature, some are okay with the room temperature. Dimorphic form. Now, some of the fungal infections, like this one, histoplasmosis, occurs towards the East Coast. Histoplasmosis. And one of the fungal infection which occurs towards the West Coast, like Arizona, California, Texas, New Mexico, this area is infected by a fungal infection called coccidioidomycosis. Please remember. These are the fungal infection. These are the most common cause of community-acquired pneumonia. That causes pneumonia also. Even though the fungal infection, we said the pneumonia is mostly bacterial. Is that correct? We said earlier. But this fungal infection, coccidioidomycosis, this is a fungal infection which causes pneumonia in community. We call community-acquired pneumonia. CAP. Now, we do have histoplasmosis, which occurs in the East Coast, where the soils are contaminated with bird dropping, birds dropping. So please remember, that causes histoplasmosis. Somewhere in Ohio, Mississippi, that area. Please remember. Now, fungal infection, we can have infection in the nails, in the hair, in the skin, and in the lung. Those are the areas affected by the fungus, fungal spore. Okay, so please remember, they do have antigen test, culture to confirm the diagnosis. Now, these are the forms: yeast, mold, dimorphic form, caused by inhalation of the infected spores of fungus. When caused by inhalation of the spores, it affect my lung. Okay. And that sometimes lead to, especially I said in the West Coast, can cause community-acquired pneumonia. Okay, so that was about lung fungal infections. Now also, that is chapter 31, I think. Okay, yeah, that's right. Now cancers, lung cancer. Lung cancers, most common cause, 80%, more than 80% people, they have a history of smoking. Industrial hazards, working in asbestos factory. Asbestos can cause lung cancers. And in some, it is a familial, running in family. Now, 80%, 95% of the lung tumors, which occurs in primary, and almost 5% are bronchial, glandular, lymphoma, fibrosarcoma, in that form. Lung cancers may be primary or secondary. Secondary means when they metastasize from some other structures, some other organ. Okay. And there are different types. Please remember, squamous cell carcinoma, adenocarcinoma. What is adeno means? What is adeno?
Glandular epithelial.
Glandular tissue. When the glands are involved, that's called adenocarcinoma. Then we do have small cell carcinoma, which is most aggressive form, highly malignant, highly malignant. You will, folks will work in the medical field, so you got to know which one is what. Now we do have large cell carcinoma also, which is only 5 to 10%. So most aggressive form of lung cancer is which form? A small cell. Okay, the lungs are the common site for secondary tumor development because of the blood supply. Due to highly vascular nature of these capillaries, fragility, okay. Highly vascular. Now, we use a term we call ventilation. What is ventilation? What is ventilation?
Blowing out CO2?
Pardon?
Exhaling out CO2?
Okay. That means you're saying air going in and out?
Air going out.
Going out, going in and out. Ventilation. Going from my atmosphere up to the alveoli and coming out from the alveoli to the atmosphere. Ventilation, two-way traffic. And a tidal volume, if you folks remember, tidal volume is the volume of air. Get air going in and out. Ventilation is just movement of air. Now, there's another term over here we use with the respiratory system we call perfusion. What is perfusion?
Gas exchange.
What is meant by perfusion? Antenna is not catching up.
How much oxygen is in the blood?
Pardon? Can you speak loudly?
How much oxygen is in your blood?
Perfusion is,
Like
we deal with the blood flow. Blood is flowing through the pulmonary capillaries, going close around the alveolus for gases exchange. That flow of blood is called perfusion. Flow of air is called ventilation. Is it clear? So flow of air is called what?
Ventilation.
Ventilation. And flow of blood?
Perfusion.
Perfusion. So we do need these two things in good condition so that my lungs can work efficiently. That's the prerequisite. Ventilation has to be enough, perfusion has to be enough. Is it clear? Now, sometimes we do suffer from some heart disease where we do have a partition, a wall, a partition, a septum between the right atrium and the left atrium. Is that correct? That wall is called what? What is the wall between the right atrium and the left atrium called? The wall or partition or septum between the right atrium and the left atrium. What is this structure called? In drop silence.
Atrial septum.
Pardon?
Atrial septum.
Interatrial septum. Is it clear? Yeah, you are 50% correct. I just add inter. Yeah. So interatrial septum. Now remember, interatrial septum. This interatrial septum has a window, has an opening or window that is called what?
Novellus?
Foramen oval, yes. Very good. Foramen oval. Now, this foramen oval has to close right after birth. I said has to close. This foramen oval window has to shut right after birth. That's a normal. If somehow this foramen oval remain patterned, remain open, blood from my right atrium goes toward the left atrium. That is not okay after birth. It's okay before birth. After birth is not okay. Is it clear? Now, this is my heart defect, which is pattern, we call pattern, atrial, we call atrial septal defect, ASD. Because of the ASD, blood from the right atrium goes into the left atrium. And not only that, blood from the pulmonary artery goes in the aorta without going into my lung for oxygenation. Look at those two things. One is oval window is open and pulmonary trunk is connected with the arch of the aorta. Pulmonary trunk is supposed to get the blood into the lung for oxygenation. So in that scenario, we do suffer from lung disease. Lung disease, because defect is somewhere else, but lung is paying the price. Because that blood is supposed to be oxygenated. And we do suffer from cyanosis and other conditions. So please remember. Okay. So I pulled this slide on this one. I mentioned about perfusion, ventilation, and so forth. That is the important again. Now, categories of the manifestation of lung cancers. Those due to the involvement of the lung and the adjacent structures. The effect of local spread and metastasis spread differently. If it is not spreading, we call paraneoplastic syndrome, which involves my endocrine gland, neurologic and connective tissues. And this non-metastatic paraneoplastic manifestation you can find in the book. It's called paraneoplastic syndrome. Paraneoplastic syndrome. Okay. And by the way, I think that was not in the PowerPoint. Click over here. A person who is suffering from tuberculosis, usually they have low-grade fever. Please remember, tuberculosis. I'm coming back to the tuberculosis because click over here, because I want to give you guys. So patients who have tuberculosis, usually they do have evening temperature, low-grade evening temperature. They give the history of sweat at night and also the weight loss. So these are the common presentation with patients who suffer from tuberculosis. So doctor, I'm fine in the morning, in the afternoon, in the evening my temperature starts going up. It's not that high, but goes up. And when I sleep, I feel my clothes are wet, sweat. That's the common presentation with patients with tuberculosis. Is it clear? So then you need to confirm with your blood test, X-ray test, and so forth. Okay, so that thing clicked in my brain right now because we said over paraneoplastic syndrome. This is a thing, sometimes patients with lung cancer, they do present some endocrine abnormality. Is it clear? But not always. Okay. So which of the following involves infections of the entire respiratory tract? Tuberculosis or pneumonia? Pneumonia. Pneumonia can involve all respiratory tissues, and due to its virulence, it's a major health risk. That's why we do have, in order to control pneumonia, we do have what?
Antiviral.
Vaccination. Because it costs thousands of lives every single year. These are stages of lung development. You guys can go in the textbook. Embryonic period, pseudo-glandular period, canalicular period, secular period, and alveolar period. Please go with the respiratory distress syndrome in children, neonate, and bronchopulmonary dysplasia. Now, I had surgery. I'm in the post-operative room. The nurse said, I'm awake. And nurse said, you need to play with this toy in my mouth. Blow air as many times as possible. In order to have my lung back to normal as soon as possible. Is that correct? Have you seen those toys in the hospital they give to the patient post-operatively? That is the important. Now, because the reason is after surgery, there are chances of surfactant. We said, what is surfactant? Chances of surfactant production might be diminished. And we might suffer from respiratory diseases, respiratory conditions. In adult, we call adult respiratory distress syndrome. And also, it causes partial collapse of the lung. Partial collapse of the lung because I didn't listen to my medical staff. They gave me toys, I said, throw away. I'm not feeling good. So, as a result of not using that toy to blow air, my lung is paying the price. Lung is now suffering from a partial collapse. That partial collapse of the lung is called atelectasis. Write it down somewhere. Atelectasis. Atelectasis is the partial collapse of the lung. That's good. It's the part because they told me to use that one and I ignored. And I pay, my lung is paying the price. My lung is suffering from epilepsy, partial collapse, not complete collapse, partial collapse. And it will take time for me to recover. Okay. These are the conditions in children, upper airway and the lower airway. So please go over in brief what is viral group, spasmodic group, epiglottitis. These are mostly viral in nature, mostly viral in nature. Lower respiratory tract we call acute bronchiolitis. These are the how those children, when they suffer from the respiratory condition, how they present. Look at the flaring of the nose. They have the diagram also. Retraction of the supraclavicular region or the space in between the ribs goes inward, called retraction. Exaggerated use of accessory muscles. Normally we don't use accessory muscle for respiration, but I'm having right now some sort of respiratory failure. I'm using my accessory muscles for respiration. What are those two muscles we use for respiration? What are the two muscles which use for normal breathing? Diaphragm. Diaphragm and anything else we use? Located in between the ribs. External intercostal muscle. External intercostal muscle. There are three in number: external intercostal muscle, interintercostal muscle, transversus thoracic. We don't use those. We use external intercostal muscle and the diaphragm. These are diaphragm, external intercostal muscles, are skeletal muscles, 100% voluntary. I can control their movement. Is it clear? But person suffering from respiratory failure, they not only involve their regular muscle, they are pulling the accessory muscle for respiration because it's so much trouble getting air in, getting air out. So they need extra help. Okay. Oh, this is done. Okay, we will move. It's time. Oh, done. Okay, now in the second chapter, disorders of ventilation and gas exchange. Let me have some gas. You folks can see the PowerPoint slide, the Zoom.
Yes.
Okay, now it's better? Okay. In the audience, anybody any questions? It's still not going, it's not in. Anybody? I can go and repeat. I don't mind to repeat. I love to repeat. Yes. Speak clearly and loudly so that I can understand.
Why are lower respiratory infections more devastating than upper respiratory?
Why the lower respiratory system is more?
Yeah, infections here at your lower respiratory.
Because of the gravity. Because of the gravity, those particles, microorganisms, they gravitate down. And plus, also in the lower part, they do have more oxygen. Oxygen, like tuberculous bacillus. Tuberculous bacillus, they cannot multiply until and unless you provide oxygen. Look at this. Normally, tuberculosis involves my upper apical part of the upper lobe or the upper part of the lower lobe because of oxygen in those parts are more. This is a good question. Okay?
So oxygen, like, kind of catalyzes it?
Oxygen needed for their survival, for multiplication. Without oxygen, I cannot survive. Okay. I think I covered pretty much. I'm saying again and again, please make sure you know the normal anatomy with this function to have your step in chapter 30 and 31. If you're shaking over there, so please. And what else over there? Yeah. If something pops up, I'm going to discuss. So let's move on to chapter 31. Okay, so this is the one, the functions, gases of respiration. We are dealing with CO2, we are dealing with O2, not the nitrogen. So primary function of the respiratory system is to remove carbon dioxide. We do produce carbon dioxide, CO2. And that CO2 we need to get rid of from the body during gaseous diffusion. Oxygen needs to diffuse in towards the pulmonary capillaries. Carbon dioxide has to diffuse out into the alveolus and then is coming out during my exhalation. Is that correct? That's how it is working. Carbon dioxide has to out, oxygen has to go in. That's what it says. Remove CO2 and add addition of oxygen. They are talking in these two words over here. They're talking about gaseous diffusion. Gaseous diffusion. We mentioned about ventilation. We mentioned about perfusion. Is that correct? You can put over here. Now, insufficient exchange of gases can cause hypercapnia. I'm pulling the bottom one first. Or hypoxemia, low oxygen or increased CO2. Now, I'm not breathing, I'm holding my breath voluntarily. What will happen, hypoxemia or hypercapnia? I'm not breathing, I'm not exhaling air out of my lung. Hypercapnia. Yes, hypercapnia, increased build of carbon dioxide in my blood. Because I'm not exhaling, the carbon dioxide stays in my blood and causes hypercapnia. Now, hypoxemia also, because hypoxemia, I'm not getting air in, also not breathing enough. Okay. Now, hypoxemia, which is low oxygen content of my blood, that's called hypoxemia, and that results from inadequate oxygen in the air. Maybe you are living in the mountain, oxygen concentration is low, that may be the cause, or you are suffering from some respiratory condition or disease that make your blood oxygen level low, or dysfunction of the neurological symptoms, or alteration in this circulatory function. Please remember the normal functions, circulation, we mentioned perfusion, perfusion, perfusion. So please remember. And as a result of hypoventilation, maybe I'm doing voluntarily, or maybe I'm having some neurological condition, maybe I had surgery, I had trauma of my chest wall, which give me a hard time to breathe. because the painful condition, I'm not breathing, that causes hypoxemia, low oxygen content in blood. Okay. Or impaired diffusion of gases. Impaired diffusion of gases, my alveolus, normally we have, normally alveolus has some fluid, yes or no? Does alveolus, which is the air sac, contains any fluid? Yes or no?
Yes.
Yes. So answer is correct. Why?
So that it, I can't remember. But it's almost to keep it moist and.
So the gases, let me make it smoother. The gases like carbon dioxide and oxygen need a fluid to penetrate. Without fluid, gases said, I can go in. So we do have a layer, a film of fluid within the alveolus for gases diffusion. Is it clear? But if I have some conditions of the lung where my alveolus become flooded with water, pulmonary edema, or pneumonia. That's what the word here says. Impaired diffusion process. Is it clear? Now, number 3, inadequate circulation of blood through the pulmonary capillaries. Or, please remember, mismatching of ventilation perfusion. Mismatching of ventilation perfusion. All these mechanisms can cause hypoxemia. All this mechanism will result in hypoxemia. Okay. How they present? Maybe they are mild form, they are chronic form. Mild hypoxemia result in metabolic acidosis, increase in heart rate, peripheral vasoconstrictions, patient confused diaphoresis, increase in blood pressure, a slight impairment of mental. These are the presentation. These are the patient usually present with mild hypoxemia. If it becomes chronic, look at the last one. My parts of the body not having enough oxygen, they become squish. It's called cyanosis. Maybe cyanosis, please go over the cyanosis. I think I put the PowerPoint also. Cyanosis are 2 different types. We call peripheral cyanosis. Another one's called central cyanosis. Peripheral and central. Peripheral cyanosis. Oh, let me see your fingertip. Oh, it looks bluish. Toe tips, all bluish. Those are areas where we see peripheral cyanosis. Fingertips, bluish. Toes, bluish. Peripheral. Nose tip. Tip of the tongue, the lips. These are the central cyanosis. That means central cyanosis is due to defect in the heart. Okay. So in order to cope with chronic hypoxemia, patient try to increase the rate of respiration. That's what we call increased ventilation. Oxygen is not enough. Let me increase my normal breathing rate so that I can get some relief by getting some oxygen by increasing the rate. Now, please remember, these are more the important terms. Hypercapnia, increased arterial pressure of CO2 caused by Highlight. What are the causes of hypercapnia? Number one, hypoventilation. I'm not breathing. Or there is a mismatching of ventilation perfusion. Remember, I said foramen oval story, that is mismatching of ventilation perfusion. Foramen oval is supposed to be closed, but it's not closed. Blood from right goes to the left. From the left, it goes to the left ventricle and then goes toward the body, which is not perfused. Or maybe pulmonary trunk is connected with the arch of the aorta, patent ductus arteriosus. Blood didn't go through my lung for oxygenation, that causes that. Please remember, hypercapnia can be caused by hypoventilation. Number two is my mismatching of ventilation and perfusion. What are we going to get? Acid-base balance become affected. My pH, we know the normal pH, you guys already said normal pH. If the pH is decreased, pH is going to decrease pH. And also, I will suffer from respiratory acidosis. Highlight and remember. So decrease in pH and respiratory acidosis, not metabolic, because the cause is in the lung. Lung is at fault, not my metabolism. Maybe the kidney will pay the price, nervous system, or cardiovascular functions. So please remember, these are the effects of hypercapnia, which results in acid-base imbalance, and there, as a result, we do see decrease in pH than normal, and also respiratory acidosis. Okay. Now, pleura, make sure folks remember what is normal about the pleura. These are on this slide. These are the disorders affecting the pleura, causing the lung conditions. Now, the term called pleural effusion. It is a abnormal collection of fluid in the pleural cavity. Normally we have fluid. What else within the pleural cavity? We have little fluid, and what else? Negative pressure. Negative pressure. Negative intrapleural pressure. That is 100% required to prevent the collapse of the lung. Now, this effusion can result in transudate or exudate, or maybe pus containing, we call purulent, or chyle. What is chyle? Anybody? Chyle is when my lymph or lymphatic vessels leak their lymph into the pleural cavity. We call chyle. Chyle, it is a whitish colored fluid, which is my lymphatic fluid, which is of course white, like milk, like. That's why we call chyle. Chylous, chyle, or serosanguinous blood stain. When the fluid within the pleural cavity is blood stained, that means gives some red flag. Maybe he or she is suffering from some sort of cancer. We call hemothorax condition, blood in the thorax, pleuritis, inflammation of the pleura, chylothorax, atelectasis, partial collapse of the lung, empyema. Empyema is the collection of pus within the pleural cavity. Empyema. Okay. Please go over with the pneumothorax. Anybody any idea about pneumothorax? What is pneumo means? Air. Pneumo means air. Thorax within air within my thoracic cavity. At thoracic cavity, they're talking about, they're focusing on the pleural cavity. The air in the pleural cavity. Normally, we don't have any air within the pleural cavity. That's why we said they are negative, no air. So somehow, when the air gets into my pleural cavity, the condition we call pneumothorax. Pneumothorax. As soon as pleural cavity is punctured, and the person who stabbed me, and he took his knife, and what he did, he left that wound open, and that open wound sucked the air into my pleural cavity. As a result, I have air within the pleural cavity, my lung on that side collapsed. But that gentleman took his knife away. If you would have left that knife, it would be good. I would go to the hospital, they put the tube, at the same time, they take the pointed weapon or whatever out simultaneously to prevent the damage of the lung tissue. Is it clear? Okay. Now, so spontaneous can happen in spontaneous pneumothorax occurs when an air-filled blister on the surface of the lung surface rupture. I've been smoking for the last 30 years. All of a sudden, middle of the night, I woke up, a severe discomfort of my chest, difficult breathing, because of my smoking habit for the last 30 years. What they did my lung tissue turned into what the smoke causes the lung, apart from lung cancer. Emphysema. Emphysema. It says if you look at the cigarette pack, it says over there. It can cause lung cancer or emphysema. And because of that emphysema all of a sudden ruptured. That is spontaneous pneumothorax. Traumatic pneumothorax caused by penetrating or non-penetrating injury. Tension pneumothorax occurs when intrapleural pressure exceeds the atmospheric pressure. So please remember pneumothorax, which is very important also. Causes of disorders of lung inflation. Condition that produces lung compression or lung collapse. If you first remember, I mentioned about the atelectasis. Is that correct? Collapse of the segment or part of the lung. I said atelectasis is the partial collapse of the lung, or part of the lung. That is atelectasis. When the collapse of the lung is complete or entire lung, comes to pneumothorax. Okay. Compression of the lung by accumulation of fluid in the intrapleural space. You guys okay with the temperature? AC? It's getting sleepy. It's getting hot, right? I'm getting, I don't know, maybe hypoxemia, maybe hypercapnia. Now, please remember the characteristics and symptoms of the pleural pain. Onset is abrupt, unilateral, or localized to the lower and lateral aspect of the chest, may be referred to the shoulder. Tidal volume are kept small. Because of the pleural, breathing becomes more rapid. And reflex splinting of the chest may occur. Sometimes we do suffer from, we call paradoxical breathing. So it is not mentioned, so, okay. Pleural effusion. So you can see pleural effusion abnormal, please remember, is an abnormal collection of fluid in the pleural cavity. We do see the fluid within the pleural cavity in different form, different time, maybe transudate, maybe exudate, maybe blood, maybe pus, maybe lymph. Diagnosis we need to confirm with the X-ray chest, ultrasound, CT scan. Okay, treatment directed at the cause of the disorder. What is thoracentesis? Thoracentesis.
Is that where they remove the fluid out of your lungs?
Pardon?
They remove the fluid out of your lungs?
By means of?
Aspiration.
Yes, very good. It's a needle. We put the needle, get the fluid out or air out, or pus out or blood out, whatever. And we do use thoracentesis for cancer treatment also. We inject some chemotherapy drug into pleural cavity. Injection of sclerosing, we call it sclerosing agent into the pleural cavity because the patient is suffering from lung cancer, cancer of the pleural cavity, or open surgical drainage. Atelectasis, please remember, I mentioned already, it is a complete expansion of the lung or the portion of the lung. Causes may be due to airway obstruction, maybe the lung compression such as that occurs in pneumothorax or pleural effusion. Increased recoil of the lung due to the loss of pulmonary surfactant. Surfactant, please remember surfactant. Maybe this surfactant, I had this surfactant before the operation, but because of the trauma, due to trauma, that surfactant producing alveoli are decreased in number, and that is causing right now atelectasis. This can happen also in the by birth defect. Patient at birth or secondary develops in neonatal period or later in life. Atelectasis. And what they do right after birth, they suck the respiratory tract to get the fluid out from the respiratory tract, because that fluid in my respiratory tract is all coming from mom's amniotic fluid. Mom's amniotic fluid, I've been there for 9 months, and that amniotic fluid is building up all day. We need to get rid of those amniotic fluid as much as possible by suction. That's the normal process. So, and also not to get rid of the fluid, but also to help the surfactant to work efficiently. Is it clear? Okay. Which of the following disorder causes abnormal accumulation of fluid? Pleural effusion. Please highlight the upper respiratory tract, the trachea and the major bronchi. The lower respiratory tract start from the bronchi up to the alveoli. I mentioned what is alveoli is. I mentioned what is the function of alveoli is. What are the different types of cells we have in the alveoli? Is that correct? Type 1 alveolar cells, type 2 alveolar cells. Type 1 alveolar cells help in gas diffusion. Type 2 alveolar cells do what?
Help with the
Surfactant.
Okay.
Yeah. Surfactant. Okay. What is the effect of if there's any blockage in the respiratory tract? It's going to hamper my CO2, and when CO2 is affected, pH is going to be affected too. So I'm holding right now my breath voluntarily. I'm not breathing, exhaling out. What will happen to my pH? What will happen to my CO2? What will happen to my pH? CO2 go up, hypercapnia, okay? What about the pH?
Down.
pH goes down. Please remember, if they talk about, pick up smart things smartly. Okay. Role of mediators, you folks can go over with this one. And also, I said, if you look at the PowerPoint, I said mucociliary blanket, mucociliary blanket. We do have the respiratory system, always they produce mucus. We do need mucus in the respiratory tract. We do need mucus in the digestive tract. Without mucus, we cannot survive. A person who smokes this mucus with cilia is becoming functionless. As I said, producing injury to the mucosal lining of the airway. Is it clear? I'm smoking, I'm injuring my mucosal lining. Okay, functions of the bronchial smooth muscles. Please remember, parasympathetic and sympathetic nerve fiber. Parasympathetic, which is coming from vagal nerve 10th vagus, that is vagal control, and sympathetic is controlled by epinephrine, norepinephrine. So, if a person is suffering from asthma, I need to give bronchoconstrictor or bronchodilator? Bronchodilator. Bronchodilator. In addition, they use also steroid also, but bronchodilator is the treatment. I need to dilate the bronchi of that asthmatic patient. Bronchoconstrictor, which is done with the help of parasympathetic, and sympathetic is working with the help of epinephrine, norepinephrine, bronchodilator. Okay. Asthmatic attack, right over here. Asthmatic attacks can be caused by allergens, respiratory tract infections, exercise, drugs, chemicals. Person need to know what causes asthma. Seldom caused by gastroesophageal reflux. There are different factors, maybe genetic or maybe environmental. Classification of asthma severity, maybe mild persistent, maybe moderate persistent, and severe. Severe persistent, patient cannot lay on the bed. It's so severe, persistent severe. We call asthmatic attack. We call status asthmaticus. I don't know if you've heard about status asthmaticus. I'm holding by the edge of the bed, holding my hand like this to support my chest wall. I'm having so much trouble inhaling or exhaling it. This is normal presentation. Patient stays on the bed, holding with the two hands and supporting the chest wall. Called status asthmaticus. Status asthmaticus. ER, not at home. Treatment at ER. Have you suffered from status asthmaticus? No severe? No. That's good. Okay.
Can you repeat the name again?
You want me to repeat or go back to
The
slide?
name of asthma, what?
Oh, it's called status, status,
Okay.
asthmaticus.
Asthma.
Ticus. TICUS, asthmaticus.
Oh. Yeah.
Now the question says, which of the following has not been implicated in development of asthma? And over here this says diet. Diet sometimes causes. Peanut butter, peanuts. Some people are allergic to berries. I don't know. Berries can cause allergic reactions. And that's what they said, diet does not affect the respiratory tract other than via allergic reactions. Chronic COPD, chronic obstructive airway disease, where inflammation is followed by fibrosis, hypertrophy of the submucosal gland, hypersecretion of the mucus, and the loss of elastic lung fibers. As a result of all these sequences, my dead space is increasing or decreasing?
Decreasing.
Increasing. Dead space is building up. Please remember I mentioned that one already. Okay. COPD, chronic obstructive airway disease like bronchitis, emphysema, bronchiectasis, and cystic fibrosis. All are important. Bronchiectasis, the chronic inflammation lead to accumulation of pus within the lung tissue. The lung tissue becomes fibrous. This is a genetic disease, cystic fibrosis. Emphysema, enlargement of the air spaces and destruction of the lung tissue. COPD, obstruction of the small airway. Now, cause for pulmonary emphysema is a history of smoking, age of onset, often dramatic. Chest become, if you look at on the PowerPoint, the one I uploaded 2 days ago, I have the diagram of the person with the barrel chest. Chest become barrel shape. That is one of the diagnostic features of emphysema. Okay, and also if you look at over there, if somebody is suffering from chronic lung disease we call bronchiectasis, the fingertip become bulged. We call drumstick finger. The tip of the fingers, they become, we call club shape. And that I can see your fingers is not normal. This looks like drumstick, clubbing of the fingers, bronchiectasis. Okay. What is cor pulmonale? Pardon? Leading to, yes, right heart is at fault and producing symptoms of my lung. And because of the lung disease, my right side of the heart is paying the price, and we are suffering from edema of the lung, of the dependent edema. I'm having enlargement of the liver and engorgement of my jugular vein. Those are the findings of cor pulmonale. Is it clear? Because of my lung disease, my right heart is getting failure. That's called cor pulmonale. By the way, when it comes to pulmonale, which side of the body or organ system has more pressure? Is the blood pressure within the lung or blood pressure within the heart?
Within the heart.
Which one has a higher pressure? Is the lung or the heart?
The heart.
Heart. Lung, we cannot have high pressure in the lung. Reason is if the blood pressure becomes higher, pulmonary hypertension, what will happen? Pulmonary edema will happen. Pulmonary affect my gaseous diffusion. So normally we do have pulmonary blood pressure is almost 1 1/5 of the heart pressure in the heart. If heart blood pressure is 100, pulmonary blood pressure is going to be 20. Look at the difference. So that's why we do need pulmonary blood pressure has to be lower than that of the pressure in the heart, always, to keep the lung dry. Okay. I'm okay, right? Characteristic type B, chronic bronchitis. Look, all those, they have a history of some sort of exposure to smoke. Okay. Please get familiar with the term hypercapnia, hypoxemia, and with this one, make sure know the pH. What happened to the pH? What causes hypoxemia? What causes hypercapnia? Polycythemia is what?
If his like body has a lot of clots?
Yes. When the red blood cells is higher than normal, that causes polycythemia. I'm living, my house is up in mountain. Air is low, my oxygen is low in my lung, low oxygen in my blood stimulates my kidney. Kidney is going to produce erythropoietin. Erythropoietin is going to stimulate my red bone marrow. My red bone marrow produces others. Look at the price. I'm living up in mountain. I'm enjoying the view, but I'm getting low, paying the price. Okay. Bronchiectasis is a permanent dilation of the bronchi and the bronchioles, secondary to persistent infection or obstruction. Bronchiectasis. Most common, they do history of cough, and they said my cough contains sometimes yellowish, sometimes reddish. Most of the time, the pus is yellowish. We call purulent cough. So manifestations are atelectasis or obstruction of the small airways or diffuse bronchitis. Look at the presentation. Coughing, production of copious amount of foul smelling. That's the diagnostic. The sputum which is coming out is not only yellowish, has a foul smell. And sometimes blood stain, that we call hemoptysis. Hemoptysis when the sputum is blood stained. Is it clear? This hemoptysis is also a common presentation of lung cancer also. Lung cancer. But purulent sputum with hemoptysis and foul smelling is my bronchiectasis. Also, patient have temperature also, always, low grade temperature. Weight loss, anemia are common. Cystic fibrosis. These are autosomal recessive disorders involving fluid secretions. This is the genetic. Autosomal recessive disorders involving the fluid secretions in the exocrine glands of what? My respiratory system, my digestive system, and my reproductive system. Folks, I think let's finish this slide and we're going to have some break. I need some break for my mandible. Yes, I need some break over here. Okay, manifestation. Look at manifestation of cystic fibrosis. Pancreatic exocrine glands secretion become blocked, suffer from pancreatitis, and that is characteristic. Please highlight and remember, cystic fibrosis present with elevation of sodium chloride in the sweat. We do perform sweat test. Sweat test, sodium chloride we need to know what is the normal level sodium chloride. If my sweat contains more than normal, then it is positive. History of nasal polyps, history of cholelithiasis. What is cholelithiasis?
Gallbladder?
Something with the gallbladder. It is a stone in the gallbladder, in the gallbladder or its duct, cholelithiasis, gallstones, or sinus infections. Sometimes the patient gives history of nasal polyp. So when you examine the nose, you can see something protruding in the nasal cavity. Let's have a break. Returning time is 11:45. I don't. So we'll go for the break for the Zoom. So 11:45 is the returning time. Okay.
Thank you.
I think I got one invitation.
Thank you. By the McDonald's one? There's no line?
No, I didn't.
That's great. Sure, at least you can drop yours.
I got pretty quick too. Do you have nutrition?
No.
Oh, good for you. You don't have nutrition?
I'm taking it to college.
Good for you. Because imagine.
I stayed up for like lunch today.
Any questions?
Join now again.
And then their friends have.
No, Patho.
Is there anything like it says fire extinguisher, pointing? Fire extinguisher.
You're just
Thank you.
Are they cute?
something like a like.
I think that sounds
Thank you.
awesome.
It's your face. It was like the front of the
Makes you remember.
Okay, folks, let's get back. Before I start my slide, please remember there's some subtype of flu. We call the blood flu and the swine flu. It is not right now in the PowerPoint. I'm not talking from the PowerPoint. I'm just saying, please remember about the flu. There are bird flu and the swine flu. Remember their code number. Code number is for swine flu is what? What's the code number for swine flu? Anybody?
Is it AV1 something?
H1N1. H1N1.
Oh, swine.
H1N1. Henry 1, Nancy 1. And for bird flu, we do have a code number H5N1.
H5 and what?
N1. N1, H5N1.
And swine was H1, H2?
H5, number 5, N, number 1.
No, for swine.
H1N1 is swine.
N1.
And H5N1 is bird flu. I think, yeah. So please remember that the swine flu is also deadly. It affects the younger age group. And the H5N1, which is my bird flu, people especially start from Southeast Asia, people working in the poultry farm, and that's caused the eruption of that flu. Everybody clear with that one? Please take home and retain. Everybody's got it? Okay. Now also, we mentioned about the fungal infections. That was West Coast, like my California, Arizona, New Mexico, Texas, which type of infection we call coccidioidomycosis. Is that correct? Remember, just C for California, C for coccidioidomycosis. Easy to remember. C's and C. Smart thing. Now, this coccidioidomycosis, which is a fungal infection, also we sometimes call valley fever. valley, V-A-L-L-Y, valley fever. Valley fever, which is my fungal infection, predominant in this zone. Arizona, California, New Mexico, and Texas. Okay, now, we mentioned about the hospital-acquired pneumonia. Is that correct? We discussed already. I'm just bringing everything over here right now. So we mentioned about the hospital-acquired pneumonia. If they intubate me because of my respiratory distress, so they said we need to intubate you, or I have some upper respiratory infection, they said we need to put tracheostomy tube, or on admission, I gave them history that I'm suffering from AIDS also. So all these conditions which can predispose me to have hospital-acquired pneumonia. My infection with AIDS and HIV, or they said we need to intubate you because you're suffering from respiratory disease. We need to make your blood oxygen level increase. We need to do tracheostomy tube. So putting tracheostomy tube or ventilation, I'm susceptible to pneumonia. Is it clear, folks? I'm susceptible to pneumonia, and that pneumonia is the hospital-acquired pneumonia. Second most common cause of death, hospital-acquired pneumonia. Okay. Okay, let's move on to, so sometimes it clicks, not all the time takes time to click, that's what I'm discussing. Please, the reason I'm discussing, that is important. Now, diffuse, let's focus on the PowerPoint right now. Diffuse interstitial lung disease. They're called diffuse, scattered. A diverse group of lung disorders that produce similar inflammatory and fibrotic changes in the interstitium or interalveolar septa of the lung tissue, of the lung. We do see different forms of interstitial lung disease like sarcoidosis, occupational lung disease, hypersensitivity pneumonitis, lung disease caused by exposure to toxic drugs. Oh, please, pneumoconiosis. Inhalation of, please highlight and remember, inhalation of inorganic dust and particulate matter. My job has those particles. I'm not using any precautions, and that results in pneumoconiosis. Next, hypersensitivity diseases, inhalation of organic dust and related occupational antigens. Highlight pecinosis. Pecinosis, I'm working in the cotton factory. Cotton workers has a characteristic of pneumoconiosis. That's called pecinosis. Pulmonary embolism. Development a blood-borne substances lodge in a branch of pulmonary artery and obstruct the flow, pulmonary embolism. There are different causes, different types. Thrombus arising from my deep vein thrombosis. Deep vein thrombosis, we call thromboembolism, fat embolism, or amniotic fluid. Fat mobilized from the bone marrow after a fracture or a traumatized fat depot. From a road traffic accident, my bone is fractured, yellow bone marrow is scattered in the body tissue, and some parts of those yellow bone marrow is carried by the bloodstream. Amniotic fluid enters the maternal circulation after rupture of the membrane at the time of delivery. Placenta removed, raw wound on the surface of the uterus might cause absorption of some fluid, that is amniotic fluid. Hypertension, we already said what is the normal blood pressure in the lung tissue and the systemic circulation. Pulmonary circulation has low pressure, systemic circulation high pressure. That's what we said earlier. Is that correct? Yes. Now, hypertension. Signs and symptoms of secondary hypertension is patient present with dyspnea and fatigue, difficulty in breathing, peripheral edema, ascites. Ascites is, what is ascites? Anybody? It is fluid, collection of fluid within the peritoneal cavity. Collection of fluid within the peritoneal cavity. We have peritoneal fluid. Normally we do have peritoneal fluid. But if there's excessive buildup of fluid, that causes ascites. Now, signs of right heart failure, which is already we mentioned, called pulmonale. Please remember, maybe today, maybe next week. Now, a disorder characterized by an elevation of pressure within the pulmonary circulation and pulmonary hypertension. Called pulmonale, we discussed that one. Right heart failure resulting from primary lung disease and long, please highlight the first two lines. Right heart failure resulting from primary lung disease. Lung is at fault. Resulting from primary lung disease and long-standing primary or secondary hypertension. That result effect on my right side of the heart. What it does involves the hypertrophy and eventual failure of the right ventricle. And how I'm going to present include the signs symptoms of pulmonary lung disease and signs of right-sided heart failure. Look at those edema, enlarged liver, engorged neck vein. All those are the signs of my right heart failure. Edema of the legs, a dependent part of the body, liver becoming enlarged, and also my veins become engorged. Those are the signs of right heart failure because of pulmonary hypertension or resulting from called pulmonale. Adult respiratory distress syndrome, a number of conditions may lead to acute lung injury or adult respiratory distress syndrome. And over here also, my surfactant become damaged. Surfactant, damage of the surfactant because of the trauma or surgery result in acute respiratory distress syndrome. Okay. Causes of ARDS, aspiration of gastric content, which might cause pneumonia also, major trauma, with or without fat emboli, sepsis, acute pancreatitis, hematologic disorders, metabolic events, drugs, reaction to drugs, and toxins. So mostly, please remember right now over here for this class, it is the surfactant at fault. Trauma to the lung tissue caused damage in the production of surfactant. As a result, I'm suffering from acute respiratory distress syndrome. Okay. Causes of respiratory failure. Maybe impaired ventilation, maybe matching of ventilation and perfusion, mismatch ventilation perfusion, or number 3 is impaired diffusion. Impaired diffusion, if you look at impaired diffusion is the pulmonary edema. My alveoli are flooded with fluid. Normally we have fluid in the alveolus, but right now it has become so much fluid, it becomes flooded, and that results in pulmonary edema. That causes pulmonary edema, and that results in my respiratory failure. Okay, impaired mismatching or mismatch of ventilation perfusion or impaired ventilation. Impaired ventilation can happen various causes, upper airway obstruction, or paralysis or weakness of the respiratory muscles, or the chest wall injury, or post-operative. These are the treatment used for respiratory failure: antibiotic, bronchodilators, ensure adequate oxygenation, establish an open airway. Sometimes we do need to perform tracheostomy or intubate the patient. Which of the following has been implicated as the causative factors for right heart failure? Pulmonary. Oh, that's the end. Okay. So today is, we have exam 3, and I believe chapter 26, chapter 26, 27, and don't forget chapter 24. Somebody emailed me today also, yesterday. Chapter 24, if you look at my discussion, during my discussion, I pulled some materials from chapter 24. I discussed those. If you listen those videos, I don't know, somebody emailed me, I don't remember, Jacqueline or somebody, Jocelyn, somebody. So, and for today's discussion, chapter 30 and 31, I uploaded the PowerPoint, also extra PowerPoint. Is that correct? From Dr. David. Please get everything from that PowerPoint. That might help for the exam and the extra credit. Extra credit, I'm working on it. That's nothing final, but I'm going to throw. Is it clear? And so today is exam 3. We are still okay, so you guys can work hard to get in the better shape. And yes, did anybody attend IPE meeting? How many? Oh, everybody. Okay. So please email. Okay, I will get that one because I'm going to give some extra credit for that one. So it's not for this. The students who are on the Zoom also, please listen carefully. I need the name you attended IEP meeting, IPE meeting, and so that when I'm working on the final result in the course total, I can add some nutrition material over there, some extra credit numbers. Okay, so please do it. And also some of the students still pending in their assignment, syllabi acknowledgement. I don't have the right now record. Still some of the students, I have 52 students, still 8 students are pending. So please check on the canvas, there's a slot there, you have to turn it in your syllabi acknowledgement. Anything else? So today's discussion, please, I said normal anatomy with function, merge with this chapter 30 and 31. That's all you need to hit the home run. I call home run. And you folks can do it home run, so it's nothing impossible. And that's it. Stay safe and healthy. I'll see you folks next Friday. Anybody has any questions before I wrap up? Anybody any questions?
How do you want us to notify you if you're at the IPE class? If we're on?
Okay, if you're on the Zoom, you folks on the Zoom, if you attend, I need the record that you attend also in IPE meeting.
On the Zoom chat?
On, not in email me. Okay? Beth, you understand that one?
Email you?
Email me that all this, I am asking all the students, email me that you guys attend IPE meeting.
Okay, perfect, thank you.
I want to keep the record.
Okay.
Okay, folks, let's wrap up. Yes, please. Let's wrap up. I'm going to see you, Cody. Let's wrap up. See you guys on next Friday. Thank you.
Oh, it was like a city class for the master program.
Oh, Professor, you're gonna check on the that question, the one with the oh, yeah.
He's watching. Yeah. Can I get your number just in case? Yeah, girl. I remember.